Chapter 11 only talks about management of shock. Okay, it will not cover management of the causes of shock. So much like any other condition, shock is not a primary problem. Patient came in with something and then they developed shock. You follow so far? Okay. So there are 4 types of shock. One thing they have in common is the patient enters a hypoxic state. All these 4 types of shock will result in low blood pressure. The mean arterial pressure here drops below 65, which is not enough to perfuse vital organs. They will have the same end result. The patient goes into a severe lactic acidosis state because the patient goes, what happens when you have an imbalance between oxygen delivery and supply? And supply and demand? You have a deficiency, right? So you have a deficit. So therefore, the patient's body, the metabolism goes from aerobic to now anaerobic, because much like any other organ, they will not shut down automatically without oxygen. They will continue to function just in the absence of oxygen. For instance, the heart will continue to pump. The brain cells will continue to function. All vital organs and non-vital organs will continue to work just in the absence of oxygen because it is deprived by oxygen. As a result, lactic acidosis sets in, and then that will set off a series of, we'll look at the stages of shock and then the consequences that result, which are namely, and we will talk about stages of shock and their effects on the organs. Particularly, they will lead to tissue anoxia and then therefore multi-organ dysfunction syndrome, and then finally death. Before death comes, though, there will be 2 sequelae that will result. You may be familiar with DIC from last semester. Okay, so shock is the #1 cause of DIC. So the patient will develop DIC, and one you have probably not heard of last semester is acute respiratory distress syndrome, which results from acute lung injury, which develops as a result of shock. Okay, so we'll cover those. I'll cover acute lung injury later in module 6, because that's where it's found. And then DIC, of course, we'll just review briefly because you discussed that already last semester. Now, these 4 types of shock develop in different manners. Okay, they revolve around the 3 elements of perfusion, which namely are the pump, which is the heart. So if the heart fails, there's 2 ways a heart can fail. It can fail directly or indirectly. When it fails directly, we call that cardiogenic shock. When it fails indirectly, we call it obstructive shock. The 3rd type of shock is hypovolemic shock. And then finally, the 4th one has 3 examples. The 4th type is called distributive shock, and they are represented by anaphylactic, septic, and neurogenic shock. So let's begin. As I said, shock has 4 types, but all 4 types result in the same thing. There will be inadequate tissue perfusion because there is low blood pressure, not enough to perfuse tissues and organs. So irrespective again of the cause, there will have tissue hypoperfusion. Now, in this instance also, you may have heard, what is troponin again? Okay, indicating what? Heart failure or a heart attack. Okay, so that indicates a heart attack, right? However, in hypoxic conditions, which you will see more of once you start practicing, patients with shock will have an elevated troponin, but this is not evidence of a heart attack. This is rather a mismatch again of oxygen supply and demand. When myocardial tissue, in this case, receives less oxygen, just like the rest of the body, will it result in myocardial death? Yes, so we call this demand ischemia. Okay, so this is one exception. There will be elevated troponin in these patients, but again, in the absence of ST and T wave changes, so there will be no heart attack. However, we still call this type 2 myocardial infarction. Okay, but this is again, the patient will not receive treatment for an MI, meaning we won't take them to the cath lab, but we will see a rise, a small rise in troponin as a result of the tissue hypoperfusion because it involves the myocardial tissues as well. So this is the end result again. The patient, this is one of the stages. The patient, if shock is not effectively treated, or the cause of the shock, the underlying cause of the each of the 4 types of shock is not effectively stopped or treated, then it will lead to multi-organ dysfunction syndrome, meaning the whole body shuts down. And when you have more than one organ failing, that snowballs, and then you can no longer stop the process, and then it's inevitable the patient will eventually die. So at that point, usually the providers talk to the family and then they instruct the staff to alert. Are you familiar with OPO, Organ Procurement Organization? Okay, they operate in every hospital. They have a representative there. So this is one of their candidates. Okay, so the OPO will be notified of a potential death, and then they will see the patient, review the chart, and if appropriate, they will speak to the family, okay, to consider, right, so, stopping heroic measures and then harvest what they could. Yes.
More than one of those, it's
Yes, they have different groups operating in the United States, but they're not really competitors. Okay, so they just, in fact, they help each other. Okay, whoever has the most need, because they won't have an exact match on their list anyway. So depending on who gets matched first, so they share information. Okay, because these organs, of course, are very valuable. Okay, again, so shock is not a primary diagnosis. Okay, so the patient goes into it after some other primary diagnosis. We'll look at the causes according to each type of shock. But again, same thing happens. There is a mismatch between oxygen supply and demand. There is inadequate tissue perfusion. There are 4 different ways this can result from. So as I already introduced earlier, so it could be an ineffective cardiac pump. So therefore, if this is not available, such as what happens in a heart attack, in heart failure, in a dysrhythmia, for instance, what are the 2 most life-threatening dysrhythmias again? Ventricular fibrillation and no, the other, ventricular pulseless ventricular tachycardia, right? So those 2 can result in what we call cardiogenic shock, because this is direct pump failure, meaning the heart failed directly. Okay, so we call that, if that's the case, then the cause of death will be cardiogenic shock. We won't say on the technical term, the patient didn't die from a heart attack. They really died from cardiogenic shock. Are we clear? So when the pump fails, however it failed directly, number 1 example again is a heart attack, or let's say fatal dysrhythmia, such as ventricular fibrillation or ventricular tachycardia, or what we call also cardiac arrest, correct? So that's called cardiogenic shock. Other causes are, of course, trauma. Okay, any other scenario wherein the pump fails, now the pump ceases to work effectively, then the cause of death will be cardiogenic shock, 0 cardiac output because the pump cannot do its job. Another is inadequate vasculature. Okay, so I'm doing the opposite here. If you notice, so this one here is saying, the statement says adequate blood flow to the tissues requires an effective pump, an adequate vasculature, and sufficient blood volume. So if one of these components or more of these components, so that means if it fails, then that means there is an ineffective pump, there is inadequate vasculature, and then there's also inadequate blood volume. Does that make sense? Okay. So I said 4, correct? Now, there's 2 in the pump failure. So I said direct and indirect pump failure, correct? So in cardiogenic shock, that is direct pump failure. The heart failed itself because something went wrong with the heart. It suffered, there's one or more blood clots blocking the one or more coronary arteries, resulting in a heart attack. Or the other example was a conduction problem, right? Dysrhythmia. Or it may not be the heart's fault for it failing, but nevertheless, the heart fails because of structures around it. An example is, you remember the fatal complication of pericarditis? Very good. So in cardiac tamponade, what happened to the heart? The pericardium was filled with lots of fluid or blood, causing it to fail, correct? So was it the heart's fault though? No, it was the sac around it that caused it to fail. What about we haven't talked about tension pneumothorax, have we? But have you heard about tension pneumothorax? Like in the movies when somebody gets shot in the chest or stabbed? Okay, so and you've seen them insert a straw or a pen on the left or right second intercostal midclavicular line. You know, you've seen that in some movies when they make it so dramatic that they, pour alcohol and then make a small incision and then insert a pen or a straw. Okay, so that's what we call tension pneumothorax. So there, it will cause the heart to fail because let me show you a photo. So we have chest trauma in that example. Let's look at this one. So this picture on the right, so look at this picture on the right, this one. So this is the left lung, this is the right lung. Okay, so the lung is supposed to be like this big, and this is the pleural space. It only contains 5 to 10 ml of fluid for lubrication. This is now what we call tension pneumothorax. So look at all this space here that's occupied by air, which is positive pressure. We're supposed to have negative pressure. Negative pressure, your lung will expand like this. But if you put positive pressure here, meaning this whole space here is occupied by air, blood, or fluid, the lung cannot expand, correct? So this increased pressure here will push the lung toward the opposite side. It cannot expand. Meanwhile, the heart occupies the mediastinum right here. That will also be pushed toward the opposite side. That will crush the heart along with the two. If you imagine there's the superior vena cava here, right? And then the inferior vena cava running right here. So both of those will be crushed, resulting in 0 venous return, 0 cardiac output. Is that pump failure? Is it direct or indirect? It's indirect pump failure. So if that's the case, this one or cardiac tamponade, or we have a few more examples. Let's say trauma also. Okay, so let's say this patient was crushed by a steering wheel, okay, or pinned against something. Then it crushes the heart. There was nothing wrong with the heart to begin with, okay, but some force around the heart caused it to fail. So if that's the scenario, then we call it obstructive shock. So other examples are a massive pulmonary embolism that could also result in obstructive shock. And we'll do a few more later when we get to that section. And then finally, When we get to the inadequate vasculature or circulatory system, what's the normal reaction of the muscular arteries to decrease cardiac output? So let's say in all types of shock, they all result in low blood pressure, correct? What is the automatic response by the body when blood pressure drops, oxygen drops, blood volume drops, sugar or sodium drops? What's the automatic response? Which is because of what hormone? Epinephrine. So sympathetic stimulation automatically sets in, correct? Releasing epinephrine, causing increased heart rate and vasoconstriction. Okay, that's the natural reaction, correct? However, in these three conditions, as I already mentioned, anaphylactic shock, septic shock, and neurogenic shock, what happens is the opposite. Patient goes into parasympathetic stimulation, which does what? Two things. Decreases the heart rate and causes vasodilation, massive widespread vasodilation.
Which shock this happens?
Anaphylactic, septic, and neurogenic shock. We'll do the examples later and the explanation later. So that's what we call distributive shock, or a more adequate term really should be maldistribution, because what's the purpose of sympathetic stimulation? Why does the body increase heart rate and cause vasoconstriction when blood pressure drops? Exactly, to cancel out it's a negative feedback response, correct? It's exactly to correct the low blood pressure, the low blood volume by, releasing also, because the RAS system is also activated, right? So there's aldosterone, so vasoconstriction along with sodium and water reabsorption. All of that tries to eliminate the initial stimulus, which is the low blood pressure. But the opposite happens in anaphylactic, septic, and neurogenic shock. We'll get to the explanation later. So those are your introductions. So those are the 4 types of shock. Management will, of course, be different for each one because they are caused by 4 different mechanisms. So the only thing in common for all shock patients is what? What can you safely give to a shock patient, regardless of the type? It's the only thing you can, because let's say when you say fluids, can you give fluids when the patient is having a heart attack? No, the only fluids you can give is very little, right? Maybe 30, 50 ml, that's it. Oxygen is the answer. Okay, because this is again a perfusion problem, correct? There's an oxygen mismatch here. There's not enough oxygen circulating by 4 different mechanisms. 1, the heart failed. Also, no direct pump failure, the heart can't pump, no oxygen will be circulated, right? Impossible. The heart fails indirectly, same thing. It cannot do its job, no oxygen will be circulated. Number 3, obstructive, any of the 3 distributive shock, blood pressure drops, and in hypovolemic shock, you lost 30% or more of your blood volume through diarrhea, vomiting or bleeding or any other body fluid loss. Okay, so same thing, even no matter how good the heart pumps, there's just not enough blood volume to go around, you still go into shock. Make sense?
So like when a patient is having a GI bleed.
Yeah, if they lose 30% or more, then that can trigger the shock syndrome already. Okay. All right, so that's your overview. Let's go now to we'll go to the stages and then we'll get to management. Okay. So here, look at this statement. Regardless of the cause of shock, the responses will be the same. The patient still ends up in hypoperfusion, then leading to disastrous damage to the tissues all over the body. So since it's a widespread all body effect, there will also be a widespread whole body response. The easy part here are the signs and symptoms, because all the signs and symptoms are due to only one thing, from the sympathetic response. The severity, though, will vary as the patient progresses through the stages. So the worse the patient becomes, then the more severe the response will be. Okay, but it'll be the same, just different severity. Meaning, let's say the MAP initially will be a drop of, let's say, 10 to 20%. It'll be now a drop of 20 to 40% in the on the next stage, and then so on. Okay. So I won't review this part. We all know that what do all cells need? Okay, how do we make ATP? Oxygen. Okay, so that's why we need oxygen, because without oxygen, no ATP, no power, then no cellular function. As simple as that. And we also know that, yes, the human body, as well as any other living organism, are used to aerobic metabolism. However, in the absence or inadequate oxygen, the metabolism switches to anaerobic metabolism. And then, of course, consequences with this type of metabolism is lactic acid accumulation. So as the acidosis becomes more and more severe, meaning the pH drops more and more, say you're now at 7.3, 7.2, 7, or less than 7 with severe acidosis, then the patient's body cells begin to die. So what is always going to accompany lactic acidosis? What happens to the potassium level? It will rise, because where did this potassium come from? Did the patient eat a whole grocery bananas? Okay, from the death of those tissues. So when cells die, they spill potassium. So acidosis and hyperkalemia always go hand in hand. Okay, and of course, at this point, what happens to the cortisol levels? Okay, so what will happen to the patient's glucose levels as well? Okay, so these are extra problems we will have to deal with. Are we clear? So acidosis leads to hyperkalemia, which needs correction. And then, of course, the glucose. Okay, the hyperglycemia also needs to be addressed, because what will happen to circulation if the glucose levels remain high? Even more compromised, right? Because now the blood flow is very thick, and that will compromise circulation to micro circulation will be compromised, to the eyes, to the nephrons, to the the microscopic cells of your organs. Okay, so that's a shortcut. So they already all mention all those. Let's go now to, and we mentioned sympathetic nervous system and the activation, as well as renin-angiotensin aldosterone system. By the way, MAP, how do we calculate MAP? Because we need to do this, because your your test question may not give you the MAP. We will give you only the blood pressure. Kurt?
Plus systolic.
Okay, so 2 times your diastolic blood pressure plus your systolic blood pressure divided by 3 equals your mean arterial pressure. 2 times diastolic plus the systolic blood pressure divided by 3. Now, you may wonder, based on that formula, why we multiply the diastolic pressure by 2. That gives you an idea of how important the diastolic pressure is, because when do the myocardial cells perfuse? During systole or diastole? They perfuse during diastole. So if the pressure during diastole is low, what happens to coronary tissue perfusion? Low. So heart doesn't get oxygen, then nobody gets oxygen, right? All right, let's go to the stages. Now we will explain or discuss septic shock separately, because all the other 3 types of shock, distributive, hypovolemic, and the cardiogenic and obstructive shock, all follow the same stages. Septic shock does not. Okay, septic shock. That's why sepsis is has a high mortality because it can be deceiving. Here in all other types of shock, it's very easy to see because what do you think will be the direction of the mean arterial pressure? As let's say if we put a graph, so imagine a line. Let's put it on the board. So let's say this is our axis, and this is the mean arterial pressure. As the patient goes into stages, let's say the stages really are called compensatory or non-progressive stage. Let's start with the initial. Initial stage is almost negligible because that's not really clinically apparent. The first real stage is really the well, textbooks call it by two names. Some textbooks call it the compensatory stage, or some call it the non-progressive stage. And then followed by the progressive stage, and then the refractory. Then death would be here. So what happens to the mean arterial pressure as the patient progresses through? Let's say they don't improve. They keep going from initial to non-progressive to progressive to refractory. The same, the predictable direction, right? It will go in the same predictable pattern. It will go down. So as the patients get worse and progress through the stages, then that means the mean arterial pressure only goes in one direction, which is down. In septic shock, it's different. There will be, we call it slightly different. So in, we'll discuss this also later. So this is, let's call this early sepsis. And then the non-progressive equivalent is what we call SIRS. Patient goes into what we call severe inflammatory response syndrome. And then the next after that will be severe sepsis. And then this will be shock, septic shock. The problem with shock is, yes, the MAP drops around here. However, when they enter the severe sepsis stage, because of the severe vasodilation, it actually stimulates the heart. So for a very short period, the MAP rises. So the patient looks good, they feel good, their vital signs improve, making us think that they are improving. Okay, because of course, let's say severe sepsis, that means a severe infection, correct? So what did you expect to be given during this stages here? Antibiotics, one or multiple? Multiple, right? So the patient here is given multiple antibiotics. So when this stage enters, will you think it's an improvement or a deterioration? We will be deceived into thinking that this is an improvement. So the patient and the family and even the nurses will say, oh, you're doing good. Okay. Yeah, you're great. Look at your numbers. Okay. Your vital signs, you look good, right? You feel good, right? Yeah. And then all of a sudden, a few hours later, patient will tank, will deteriorate rapidly, and then death follows. Okay, you may have heard stories of these if you know or recall our COVID patients 4 years ago now. Okay, so these are very common stories because the death in COVID patient isn't COVID. They died from sepsis. Okay, they died from septic shock. So this is a very common story, and And the families of survivors, if they were there at that moment, you know, especially just FaceTime, of course, they couldn't be there at that point. But this is a very common story that the patient at one time woke up, okay, was able to communicate, they felt good, they even asked for food, okay, but then a few hours later, they died. Of course, not everybody followed the same pattern. Some obviously survived, but this is the majority of those that what happened to the majority that died, okay, during that tragic year. Yes.
So what caused the sharp decline?
It's actually just a manifestation of, go back. So this here is not really an improvement, nor is this a, you know, like a surprising decline. This is just how the sepsis progresses. The explanation is the patients, it'll be better explained when we get to that chapter, okay, so that I won't have to switch from one chapter to another. Okay, I'll get back to your question later. So these are the all other types of shock follow the compensatory, but keep in mind the NCLEX, I don't know which textbook the NCLEX will refer to, but other textbooks will call this non-progressive, okay? So either compensatory or non-progressive stage. Then second stage is of course progressive. And then we have the irreversible, also known as the refractory stage. Refractory meaning unresponsive, okay, which is not any different from irreversible, right? So take note that the earlier the interventions, then the higher the patient's chance of survival. So which stage would that be? That would be here in the compensatory stage. This is the best stage for you to intervene, give all the interventions. I'm not saying that the patient won't survive if they enter stage 2. We can still give heroics here in stage 2. We will place the patient in ICU, give them vasoactive drugs, meaning, you know, drugs that will improve blood pressure. So we give them dopamine, levofed or norepinephrine, you know, those high vasoactive infusions, okay? So we put a central line, we give them those vasoactive drugs. They can survive, okay, when they reach stage 2. But when they reach this stage here, very few people come back. Usually when they reach irreversible or refractory, that's unstoppable. Okay, they will reach the septic shock state and then eventually die. As far as manifestations, I believe the textbook has a right here. Okay, so there is a table, so making it easier for you. So table 11-1 are your manifestations. So I could, because as mentioned by this statement here earlier, so the identification of the stage allows you to choose what interventions to use. I forgot already, but it's written here somewhere that's the case. And here's another support. Current evidence suggests that the window of opportunity that increases the likelihood of survival occurs when aggressive therapy begins within 3 hours of identifying a shock state. So we will look at later when we get to management, the bundles. So we have, because this is a very common diagnosis. So patients come in with, let's say, unless they're already septic when they come in, but we still need to identify the cause, correct? Meaning, why did they become septic? So when they come in, usually we draw the usual, what are the 3 most common sources of infection? It's either UTI, pneumonia, or, well, let's say this patient came from home. So it's either a wound somewhere, correct? So the patient has some wound in or a blood infection, or it could be pneumonia or a urinary tract infection, especially if the patient's 65 or older. So we'll draw all those specimens to see where is the source of this infection, and then identifying what stage the patient is in. So to identify the stage, we will look at table 11-1. There is a criteria here known as depends on the author. Most facilities will use either SOFA or I forgot the other scoring criteria. But anyway, if the patient meets sepsis criteria, they will immediately implement the bundle. So let's finish the signs and symptoms first. As I mentioned earlier, the manifestations are really the result of the sympathetic stimulation. Look at the manifestations. So increase in heart rate, isn't that sympathetic? Yes. The increase in respiratory rate, same, right? Regardless if the cause of the shock is respiratory in nature, it will cause a rise because, of course, hypoxia will stimulate rapid breathing. The skin, there will be a change here. If you look at the pattern here from this is compensatory, non-progressive, and irreversible. Cool and clammy here, but in the case of sepsis and the anaphylactic as well as neurogenic shock, because there is vasodilation there, what will be the first skin manifestation in those patients?
Or
They will be flushed, warm, right? Instead of cold, clammy, and pale. You understand? Because this one, again, all the other types of shock will be vasoconstriction, correct? Except which three? Sepsis, anaphylaxis, and neurogenic shock, because those three have vasodilation. However, when they reach the non-progressive stage, it's now paradoxical. So they may begin warm and flushed, but then when they get worse, then they turn cold and clammy. Do you follow? All right, so that's the pattern in the three distributive types of shock. So here, why does the urinary output decrease when there is sympathetic stimulation? Okay, this is the aldosterone effect, right? So when the aldosterone is released, of course, your urinary output drops because what happens to sodium and water? They are reabsorbed. Okay, now for shock, what did we say was the minimum MAP? 65, correct? The minimum urinary output here, yes, we can still do 30 ml per hour, but in critical patients, we don't really go with 30 ml per hour. We now go with 0.5 to 1 mLs per kilogram per hour. So we will be happy if they make 0.5 or better. Okay, so better if it's 1 ml per kilogram, but 0.5, okay, we'll take that. All right, so that's the minimum, 0.5 ml per kilogram per hour or better. So what's the cause of the confusion here? Again, hypoxia, okay? So cerebral anoxia now. So no oxygen to the brain causes CNS changes, agitation, and then with acid base, of course, there is acidosis. So initially in compensatory, why alkalosis? Because of the hyperventilation. Very good. So this is only a short time. Then as the patient progresses, then they'll go into acidosis. What's the cause of the metabolic acidosis? Remember, there's anaerobic metabolism now, lactic acidosis. Okay, you follow? And of course, we already mentioned earlier what happens to the potassium level here. Okay, what else will also rise? Potassium and glucose. Okay, so glucose will start rising. One thing that will also rise potentially is uric acid. Where did the uric acid come from? Also from the dead cells. Okay, so dead cells release both potassium and uric acid. Right, so This could be a select all that apply question. I can do it like that, or I can do a matrix type. No, the categorization. I gave you one sample last semester wherein you drag the answers in different columns. Okay, so I can also do it like this. So I'll put 3 columns, putting compensatory, progressive, irreversible, and then you just drag the items there, the findings. Yeah, Joy?
No.
Okay, that means yes. Please remember that I won't grab these word by word. I'll give you actual values.
Oh,
Okay? So let's say I won't say PaO2 less than 80. I'll give you a PaO2, which is less than 80 or over 80, whatever. All right? Or I'll give you an actual, so the patient will have a weight there in the scenario, and then I'll give you the urine output over how many hours. Okay, because that's what you'll see on an actual chart. Okay, so it won't be a table like this. So you'll see, you still a table on the lab results and your vital signs graph, but that's about it. And I'll also give you the blood pressure, initial, and then what is it now? And then you have to calculate the MAP yourself. Understood? Alrighty, very good, children. Management. Some management, like I said, management is geared toward the cost, correct? Because there are 4 types of shocks, so expect 4 different types of or set of interventions. Except again, what's the most common thing you can give all of them? Oxygen. So regardless of the type of shock, give them oxygen. So what's the next step after giving oxygen? Knowing that the interventions vary for each type of shock. So after giving oxygen, what's your next goal? Okay, someone fluids, you said. Okay, so you're giving vasoactive drugs. So we have here, everybody agreed on oxygen, and then Joy said fluids. You said vasoactive drugs. Who else? Is that really the next step? Do you know what type of shock this is? Okay, so we have to determine there's what type of shock is this, okay? Because remember, the intervention is specific to the type. Can we give fluids? Let's say it turned out this is a heart attack. Now you gave 1 liter of fluids. So that will kill the patient, right? So let's say you also give vasoactive drugs. What if this is cardiogenic shock? Then you just made the arteries even worse, more constricted. So you worsen the heart failure or the cardiogenic shock. So therefore, what's the next step after oxygen? Tests will have to be done. So since we don't know 4 types, so what sets of tests will likely be ordered? Let's start with blood. Okay, we'll do chemistry, right? Chemistry, CBC, what else? Yeah, because CBC will show you, is this a hypovolemic shock issue, right? So what will, if it is hypovolemic shock, what will the HNH be? Hematocrit will be? And hemoglobin will be? Very good. What if it's a, well, in all types of shock, what will the chemistry show? Lactate, right? Lactate will be high. What else? Potassium will be high. Glucose will be high. All right. What other blood tests do we, you said draw blood for hematology, chemistry. What other blood? How do we know the pH? Okay, we need arterial blood to check the pH. What else? Because we have to cover all bases. What is this is shock. Patient's blood pressure, the MAP is less than 65. So we need to be quick. Okay, so we go for D-dimer. So you're looking for other possible causes, right? This could be a pulmonary embolism leading to what type of shock? Obstructive, very good. Okay, so it could be anything. So you draw also, can we draw BNP? Yes, and troponin, very good, in case this is cardiogenic shock. So this is really quick, okay? So you have a few minutes to identify the type of shock. Okay, so we can proceed with other interventions because right now only oxygen is being administered. Okay. What else? So we will have to look at the patient's other symptoms to determine what is the likely cause of this patient's shock. So therefore, we can make a diagnosis of what type of shock we are dealing with. Of course, it would help also what happened to the patient, correct? Recently. But if this patient was found out there in the snow, is that easy? No. Found unconscious outside, it could be anything, right? It could be a cardiogenic shock, could be obstructive, it could be hypovolemic, or it could be any of the anaphylactic, or let's say this is injury, this is spinal cord injury, then it could be neurogenic shock as well. Okay, so here's something to think about. A quiescent alert. So by the time blood pressure drops, damage has already been occurring at the cellular and tissue levels. So that's the effect of shock on body tissues. So we discussed oxygen already. Fluids may be started, but in case it's cardiogenic shock, the fluids, were we giving a lot or? Okay, just a little bit, okay? And then until we rule out that the troponins are negative, ECG is negative, the cardiac monitor doesn't show anything, then we can proceed with the fluid administration. Okay, so we'll increase the fluids. We continue the oxygen. So we need an arterial line. Now, the benefit of an arterial line is multiple. One is you can easily draw arterial blood here, so you don't have to keep sticking the patient for a blood gas, because we need to monitor the pH constantly, because that's the basis for our interventions. Okay, so what drugs to give based on, or how much fluids to give based on the patient's pH. Okay, how bad is the acidosis? So we need to constantly monitor arterial blood. If needed, meaning the patient's blood pressure continues to be below 65 MAP, then the patient will have to be intubated. We'll discuss intubation under module 6 and mechanical ventilation as well. Okay, let's review central venous pressure. What is CVP again, and what's the only way for us to monitor this? I discussed this under heart failure last semester. So what instrument needs to be inserted to monitor this? A pulmonary artery catheter. You remember that? No? Okay, very quickly. So what is a pulmonary artery catheter? It's also called the Swan-Ganz catheter. You remember now? Okay. All right, so this is the Swan. It's a central line, basically, with a balloon at the tip. You remember now? Okay, so this is inserted to the neck, the right jugular, and then they'll inflate the balloon, and then the balloon will be carried by the blood flow to the right atrium, right ventricle, and then we stop at the pulmonary artery. That's why it's called a pulmonary artery catheter. So what's the purpose of the catheter? It will measure the pressure inside the heart. Rather than measuring blood pressure on the arm, this one will measure blood pressure inside the heart chambers. So will it give you real time
Yes.
data? Yes, as it is happening. So whatever you do to the patient or not do will be reflected directly by this instrument. You can also pass meds through it, but the most important purpose of the catheter is to measure the pressures inside. So the right atrial pressure, so imagine this is inside the heart. Okay, so the heart is here. So this is now in the pulmonary artery. So if you imagine this is in the pulmonary artery, that means where is this thing? This is in the right ventricle and this is in the right atrium. Okay, so on the right atrium, that's where we measure central venous pressure. It's also called right atrial pressure. So what data will the right atrial pressure give you? Pressures from which side of the heart? Well, this is the right side, right atrium. So what data will this give you? Pressure from the which side? The right side of the heart. Okay, simple as that. Now the pulmonary artery tip, this one. Where is this again? In the pulmonary artery. So which data will this give you? Pressure from which side of the heart? The left side. Okay, so you may argue, oh, this is not in the left atrium. Well, it's impossible to put it in the left atrium. Okay, it will have to stop at the pulmonary artery. However, whatever happens on the left side of the heart, the left atrium and the left ventricle, is it reflected on the pressures on the pulmonary arteries? Yes, because now once the left side fails, that means what happens to the pulmonary arteries? Congestion, correct? Because the left side won't pump effectively, then there will be congestion in the pulmonary artery. So we don't need to put that catheter into the left atrium because we can't anyway. But the information it gives, because it's in the pulmonary artery, it will reflect left side heart pressures. Okay, so if this patient is about to go into failure, what will happen to those numbers? The heart fails. It's not pumping anymore. So what happens to the pressures? It rises. Okay, because remember, the heart has one job, which is to pump blood. If it stops pumping, therefore, what happens to the pressure? Increases because blood is no longer moving in and out. So the pressure rises because of the congestion reflected directly using this catheter. So is it useful? Very useful. And you can buy it for $778.99 and put one at home. Okay, so let's measure your hemodynamic pressures. Okay, so let's discuss positioning. So this is also applicable in all types of shock. So which position will we place our patient with shock? Look at the picture. Because your MAP is less than 65. So which is the best way to increase blood pressure? This one right here. Because if you raise the leg, then venous return increases, correct? And then cardiac output improves. So what do we call this position? What is this called? Joy. Trendelenburg would be if including the head would be upside down. Meaning if this is modified Trendelenburg. Okay. So if the head is flat and then the leg and feet are raised, meaning it goes like this, that means that is modified Trendelenburg. Are we clear? All right. We can do Trendelenburg. However, most of these patients have an airway. So therefore, is it a good idea? I mean, they're ventilated. No. Okay. When you say airway, you know, I mean an artificial airway, you know, endotracheal tube. Okay. Reducing anxiety. This is especially if the patient's already in the ICU, already on a ventilator. They have an airway. Family will be distraught and not really helpful at this particular moment. So make sure somebody is taking care of them. Okay. Don't slap them around either, because they'll just be even more angry. So make sure somebody is just talking to them, okay? Because they're not helping if they're all over the room and not really helping the scenario. Because here you are busy with the patient, and then they can't help it though, okay? So it's natural reaction. I mean, how would you react if it's your child? Are you just gonna quietly stay in the back? No, you'll be asking, right? Yeah, what? And then if you're already in nursing, so you know some things, but at that moment, are you really in the right state of mind? If it's your own child? Not really, right? So about clarifying advanced directives, this is important because the mortality of shock is quite high, especially septic shock. So we need to know what is the patient's advanced directives. We need an order. Are we full code or are we DNR? Okay, so that's the one of the things you need to keep in mind, because they could die anytime. We need to know what to do. Okay, are we doing chest compressions or leave them comfortable? Keep them comfortable. All right. So let's go to the progressive stage now. In the initial or compensatory stage or non-progressive stage, the patient is still compensating. Okay, that's the whole purpose of the sympathetic nervous system stimulation, but doesn't mean we don't give any interventions. Okay, so like I said earlier, that's the best time, right, to do your interventions. So manage shock and then stop or treat the underlying cause that led to it. Progressive stage, now the patient's MAP is getting worse. We now go with vasopressors at this point. By the way, the signs and symptoms, I know it was on table 11-1, correct? But there are some manifestations mentioned here, so I can grab them also and put them on the exam. All right. Do you, oh no, we haven't done this yet. Okay, so let's explain this part here. When the patient enters this stage, recall the last time you had a pimple.
No.
Pimple.
Yeah.
Okay. Or in high school, okay, we had lots of pimples, right? In high school. And then remember one particular pimple wherein you pricked it. Okay? It's just really nasty. You're looking at the mirror, so you popped it, okay? And then the juices came out, splashed on the mirror. Okay. What happened to it afterwards? Yes, there was bleeding, but then you patted it with a tissue. Then what happened? What came out after the blood stopped, the bleeding stopped? So there was fluid, right? Did it just ooze once or twice? Constant, right? So what happened there? Where did that fluid come from? And why did the pimple do that? What happened to the blood vessels there, therefore? They became, so here's the answer here. So they became very permeable. So what caused them to be very permeable? What caused the increase in capillary permeability? Okay, the inflammatory markers. So this is now, remember when I drew sepsis earlier? So this is now the equivalent right here. So when the patient enters the progressive stage, or in the case of sepsis, it's the SIRS stage, this part causes this reaction, increased capillary permeability, because just like what happened with the pimple, our body is not very effective in fighting off an injury or an insult. We respond by sending so much inflammatory substances there. Biochemical mediators, they're called. These are the histamines, the cytokines. These are the pro-inflammatory substances. So what do pro-inflammatory substances do? They cause capillaries to not only dilate, but also become increasingly more permeable. So normally, small molecules that are not supposed to come out of the capillary, like albumin, for instance, they now leak out. Of course, what will follow large molecules? Water through osmosis, correct? So water moves from an area of lesser to greater concentration. So if the large molecules leak out of your capillaries, water will follow them. So that's causing the leaking in your pimple. And this is now the start of acute respiratory distress syndrome. Because what is the structure of your alveoli? No, an air sac. What do they look like? This is an alveolus. What is wrapping them? Capillaries, right? How many alveoli do we have? Hundreds of millions of alveoli, each one wrapped with a capillary network. Now imagine that severe inflammatory response syndrome that I mentioned does not occur, unlike the pimple wherein it occurred right here where the pimple is. In this particular scenario, it's occurring everywhere, all over the patient's body, all over where the cells are receiving less oxygen. That's how our body responds. So if these things, for instance, leak fluid, just like the pimple, where will that fluid go? This is lung tissue. And these are microscopic areas of your lungs. Where? Inside the alveolus, inside those air sacs. So when they leak, they go inside. So what happens to the alveoli? They become filled with fluid, right? They fill with fluid. Now, can gas exchange occur with fluid in your lungs? So this is now what we call ARDS. So this will start happening in the alveoli. So this is just one body system, okay? This is just in the lungs. And this will occur everywhere else. So when you look at this patient, they will have edema in the arms, the legs, in the sacrum, anywhere it is dependent. Okay, they'll start having dependent edema because they're now in this state. So this is now happening in the progressive state, okay? So there's interstitial edema occurring all over in the lungs, in the arms, everywhere in the body. If we successfully somehow treat, that will stop. However, with the increased capillary permeability, we don't really know when this will stop. Okay, this reaction right here wherein the capillaries leak, it's self-limiting though. We just don't know when exactly it will stop, right? It will eventually stop. Whether or not the patient is alive, we don't know. Okay, but it will stop eventually. But again, if you successfully treat it and we restore aerobic metabolism, lactic acid decreases, potassium levels start going back to normal. The patient's urine output increases, and this fluid goes back into the capillaries, okay, restoring blood volume, fluid volume, and then the patient recovers. So here's what I meant earlier. So once the pulmonary capillaries begin to leak, then this will lead to ARDS. The condition is known as acute lung injury. Now, take note that acute lung injury, like heart failure, can be direct or indirect. An example of direct acute lung injury is, let's say, when you aspirate secretions. Say, you're drunk, Miss Peguero, had way too much to drink, She was passed out on the sidewalk. She started to vomit. She couldn't turn her head because she's dead drunk. So she aspirates all the taco and hot sauce that she had a couple hours prior. They all went into her lungs along with the stomach acids. Is that acute lung injury? Yes. Another example is, let's say you drowned. Okay, you didn't drown in the swimming pool. You drowned in the sewer. So all the my waste and Kurt's waste, from our homes went into Peguero's lungs. Okay, so is that acute lung injury?
Mhm.
Yes. We can also have indirect acute lung injury. Let's say any infection anywhere in your body except in your lungs. That's indirect acute lung injury. Okay, we'll have more examples later when we get to the ARDS chapter.
So like COVID?
Same acute with COVID though, is that direct or indirect? That is direct acute lung injury, right? So yes, COVID infection causes pneumonia, and then pneumonia will cause sepsis and then go into shock. And then again, the sequelae is, now this is all in addition, okay? So the patient is still in shock. And then in addition to that, when you reach this stage, they develop ARDS. Okay, making it hard to ventilate this patient. So of course, the patient will be given a intubated and put on a mechanical ventilator. So we'll do that in chapter 19, all right? Module 6. So for cardiovascular, of course, the sympathetic nervous system stimulation continues. The heart rate now exceeds 150. Neurologic, this is in response, of course, to the acidosis, metabolic acidosis, and the continuing hypoxemia. Kidneys begin to shut down. What is the urine output here now? Obviously, oliguric already. Okay, so less than 400 ml per day. So less than 0.5 ml per kilogram per hour. The liver, so this is another reason why that and also the hyperglycemia occurs, okay, because of when the liver starts shutting down. There will be no more peristalsis. So the patient also has increased, because what happens to cortisol again? Rises. So what happens to gastric acid secretion when cortisol levels are high? Also increases gastric acid secretion, so causing ulcerations and then eventually GI bleeding. There will also be nausea, vomiting here because there is no peristalsis now. And once the GI tract shuts down, remember the pancreas is part of the GI tract. So will there be insulin production? No, contributing to further hyperglycemia. Blood, there will be decreased blood production here. So this will depress the bone marrow, so making everything else worse. And the dreaded DIC, all happening, or at least beginning to happen, in the progressive stage. Okay. You still remember DIC, right? And the stages of DIC are in clotting first, and then you exhaust the platelets and clotting factors, and then bleeding results. Okay. So ARDS and the DIC is happening on top of the shock. Okay. So you still want shock? Okay, so this is, you can understand why mortality is high, right? All right. So at this stage, like I said, we continue to aggressively treat the underlying cause while also managing the shock. Now, we will institute the bundle here now. I'll get to the bundle later. But part of the bundle are these. So aggressive hyperglycemic control only with insulin. Then we'll place the patient on H2 receptor blockers. They're always given twice a day because they only work for 12 hours. They have a 12-hour half-life. PPIs, however, will be once a day. But at this point, the doctors want H2 receptor blockers over PPI. When the patient's stable, then we'll switch to PPIs. This is our target, 80 to 100. No, sorry. Under 180. Okay. We don't want the blood pressure, although this is normal, we don't want it too low either. Okay, because the patient do need a source of energy. Remember, this patient is not eating. Although, so here's the target, less than 180, as already mentioned. The patient is fed though. We put in an NG tube and begin feeding the patient as soon as we get peristalsis. All right. What are these two complications again that occur during the progressive stage? ARDS and DIC. As I said, we'll skip the mechanical ventilation and airway management until chapter 19, module 6. Irreversible stage, I won't even discuss this because there's really nothing you can do here. No matter what you do, we're losing the patient. Do patients survive after this stage? Of course, yeah, very few, but those are the miracles, okay? But very little. Charlie Sheen has a higher chance of coming back than these patients who are in the irreversible stage. So we'll skip that. So there's really nothing we can do. So here, if you look at the, I mean, you can read it, but there's a reason why we call it irreversible. Does that make sense? There's really nothing you can do. The again, you call OPO because they may still be able to, because we can keep this patient alive. I mean, the body's alive, so there's a chance you can keep some organs alive, you know, for harvesting, but the brain at this point is clinically, I mean, these patients are, you know, again, irreversible. Okay. So just keep the patient comfortable, support the family, let them grieve. You know, it may take different times for them to accept, go into the acceptance stage of grief, but just support them. Okay. And this is the hardest part because it may seem like because you have other patients, right? Because this is not your only patient. So you have other patients and then here you are taking care of other patients. But these patients, these family members need your attention, right? So you just need to take turns, right? So okay, who wants to talk to them now? Okay, so I'm done with MedPass. I'll go, you know, stay, just answer questions. Okay, so they'll have plenty, because otherwise, if you don't address them, then they'll start calling lawyers. Although, you know, we can defend ourselves, but you don't want to go into that hassle. Okay, so you just want to support them, no, rather than ignore them, because if you ignore, again, they'll start, you know, calling lawyers. And like I said, yeah, we can we have no problem with legal issues, but you don't want to get to that point. Okay, so just answer the questions, give support, give them time. Never give them a reason for a lawsuit. Okay, so this part here is general management. We'll have to go to the individual on the next few pages. So in general, oxygen, if needed, we will intubate and put the patient on a ventilator. Fluid replacement, only if appropriate, right? So which types of shock, based on so far your understanding, which types of shock will receive fluid replacement? Hypovolemic, definitely. Who else? Can we give it to anaphylactic? Yes. Septic? Yes. Neurogenic? Yes, we can. Although I'll go into neurogenic a little bit later. Vasoactive, yes, if appropriate. Okay, vasoactive again are the vasoconstrictors. Okay, norepinephrine, dopamine, and nutritional support. This is through enteral feeding. Okay, we'll insert an NG tube. Fluids again, be careful. Make sure it's not cardiogenic shock, right? Before you start fluids. Blood transfusions if needed also. What could go wrong with the fluid administration? Fluid overload. Okay, so make sure you only give enough. So because these are large volumes we're giving, I'm talking 1 to 2 liters per hour. So that's a lot of fluids, right? So make sure it's still appropriate. So what would indicate that you're giving too much now? Blood pressure. What else? Urine output. You have too much urine output now. Or you could have evidence of fluid overload, heart failure, signs and symptoms. And lung sounds will be okay. The benefit here of having a Swan-Ganz catheter, remember the arterial line, is you don't have to wait for the crackles to determine fluid overload. Because can you see it on the monitor? Yes, because that catheter measures again internal pressure. So if the pressures start going high and then you're giving fluids, what does that tell you? You're giving too much now. Okay, so that's the benefit of having a pulmonary artery catheter.
How do you monitor the catheter? Like every hour, every 2 hours?
Okay, so here you see there are many see here you have many lumens, right?
Mhm.
Two of them, the one measuring right atrial pressure or central venous pressure is attached to one. The other is attached to monitor pulmonary artery pressure also. So those two will be displayed on the screen. So you can see the numbers.
Okay.
Right? So I don't know the page where the pressures are in your book, but right atrial pressure is between 0 to 8 millimeters of mercury. And then the pulmonary artery pressure is between 4 and 12 millimeters of mercury. Okay, so that's again the benefit of having a Swan-Ganz catheter or pulmonary artery catheter.
It was 412.
4 to 12, I think. Please look at this statement here because modern physicians do not like putting a pulmonary artery catheter anymore because yeah, it's good when you watch it on the animation when when you see it on YouTube when they insert it, but in reality the insertion procedure can have lots of consequences because imagine, look at this, it's a catheter, right? It's a catheter. You think this will stay stiff when you insert this thing? This will flap around like a wet noodle, right? During insertion. So can this bounce around and then hit your SA node? Yes, and then remember the valves that they have to pass through will open and close. So it's not easy inserting this thing. You see what I mean? So consequences here, there's complications putting with the insertion part. Plus, not to mention, is this a foreign object? Can this be a source of an infection? Yes, that's another reason. But the information, the data that it gives you is very crucial though. So again, not all doctors are still using them. That's why this statement is here. Circulating blood volume, fluid responsiveness. So there are other ways you can measure CVP without a pulmonary artery catheter, although not as accurately though. I already mentioned the eclampsia, so having a central line like that, high risk for infection. One thing about vasoactive medications is these are again your vasopressors. They should not be given through a peripheral line. Dopamine, norepinephrine are very irritants, are highly irritating. However, in emergency situations wherein we need to start it before we can have a central line, it can be given through a peripheral line. However, if it does infiltrate, we call it extravasation. No, it's not just the vein. It's going to cause, this is what extravasation looks like. Okay, so that is extravasation. Let me show you a good picture. One that's already debrided. So these are early, okay? So that's extravasation like that. So this is a extravasated fluids. So this could be from norepinephrine or any other vasoactive medication or any other irritating drug. They can destroy tissue, which will cause a complicated wound, which requires a series of cosmetic surgeries. So it's basically tissue necrosis. Okay, so that's your number one. So these are all from extravasated medications. So they should be given through a central line if at all possible. All right. But if you have a patient receiving it through a peripheral line, what's your number one responsibility?
Monitor.
Making sure what? That vein is still in place. That catheter is still in that vein. All right. So you flush it periodically, check for blood return, making sure is it still in the vein. Because you don't want to have to deal with extravasation. Plus, this is a non-reimbursable complication. Look at that. You have to do surgery on that.
Oh, like a sling graft?
Probably beyond that, because if this reaches muscle and bone, you have other problems. You have even bigger problems. All right. So your number one is to make sure the patency of your peripheral line. All right. Because you have no choice. Let's say the patient needs it. The doctors can't put in central lines yet. The patient is damned if you don't give it. So signs and symptoms of extravasation include pain, burning, coolness. You know, signs and symptoms. Do you know what infiltration is? How do you know something has infiltrated? There's swelling, edema, right? The skin feels cold. Okay. So this one though, unlike IV fluids, which cause infiltration, this one, these IV infusions, these vasoactive drugs are very irritating. They're very vesicant. So they will destroy tissue. Okay? They'll cause necrosis and sloughing. And the only intervention when you see that is to stop and then report to your physician. What do you do? Stop and report. Keep in mind, this is also standard. So we don't stop it abruptly. Okay. So let's say your dopamine is infusing at, say, 16 micrograms per minute. So it needs to be, and the doctor's orders, okay, discontinue it. Can't discontinue by just turning off the pump. Yeah, it has to be titrated down. So you go every hour, you go, by 4 increments, maybe, instead of 16, you go 12, 8, 4, and then at 4, you can go down to 0. Okay, from 4, because that's the minimum is infusion is 4 mics per minute, and then you can go 0. Nutritional support. Look at the calorie requirements of shock patients. More than 3,000 calories daily. Are they exercising?
No.
They're just laying there, right? So you can imagine the hypermetabolic state that they're in if they require more than 3,000 calories. Okay, so that's how sick these patients are. So we accomplished that through enteral feeding. We already discussed enteral nutrition last semester. And did we ever talk about CLABSI? Oh, central line. I did, right? During lab, right? Second week of lab last semester?
Yes.
Yeah, under central line. So here are your bundle. So we have a bundle for sepsis. We also have a bundle for CLABSI. And that's your bundle. Okay. Very good. Select all that apply. Joy's favorite. Okay, and here are your vasoactive agents so that you're familiar with the names. Take note that because they cause vasoconstriction, are they free from complications? What effect will they have on the cardiac function? Because they don't choose which arteries to constrict all arteries. So if they constrict coronary arteries, what will happen? What will the patient feel? Chest pain, right? So it may require a dose adjustment if the patient experiences or reports chest pain. These are potent vasodilators. This cardioselective vasodilators. So they increase blood flow to the coronary arteries, increasing cardiac output while decreasing preload and decreasing afterload. And these are your most common infusions. So norepinephrine, if you hear somebody say Levophed or Levo, they're referring to norepinephrine. Okay. So this is again a very vesicant medication. Ideally should be given through only a central line, right? A big blood vessel. But what is your responsibility if it is given through a peripheral? Monitor for extravasation. All right, let's take a break.